Welcome back, everyone. So for those of you who perhaps weren't able to make the question and answer session, let me introduce myself. My name is Joseph Gigante. I'm an academic general pediatrician at Vanderbilt Children's Hospital, and I'm also a Practical Peds Committee member, as well as the course director for this course. So our speaker this morning is Dr. Angela Hogan. Dr. Hogan is presenting the title of her session is Eczema, Mischief Managed. Dr. Hogan will be taking questions throughout the morning, so please use the conference INO in order to get there, or how to get there is go to aapcme3.cnf.io to submit questions or to upvote someone else's question. Those questions that are the most popular will be asked first. Be sure you have selected this seminar on the aapcme3.cnf.io site before submitting your question. I think you can also see it on your screen as well with the QR code. So thank you for being with us this morning, Dr. Hogan. Dr. Hogan, the floor is yours.
Good morning or afternoon, depending upon where you are in the time zone. And again, my name is Angela Hogan, and I am a pediatric allergist immunologist in Norfolk, Virginia. I am at the Children's Hospital of the King's Daughters, and I'm a professor of pediatrics at Eastern Virginia Medical School. And our goal today is to give you the allergist view of atopic dermatitis, which we see a lot in our clinic, and hopefully give you some pearls on how you might be able to approach this patient in your office and be able to enable them to get the best care possible and deal with the chronicity of this particular entity. And my title does have a little Harry Potter hint because we are Harry Potter fans in my neck of the woods as well as in my family. So these are my disclosures for you today, and they're also listed on my recorded slides. And while they are two pharmaceutical companies that I speak for or on their advisory board, they in no way will affect our discussion today, and certainly I don't intend to discuss any unapproved things that are not at least supported in the medical literature. So what we're going to do is we're going to try to understand the pathophysiology of eczema a little bit better, discuss a little bit about the skin barrier, some of the immune response. I promise I will not make it an immunology lecture, but there are some key things that I want you to know about. Then we're going to discuss what the triggers are for atopic dermatitis, and then we'll talk about what you really want to know is is my view of applications of medications and procedures and things so that we can optimize these particular children. So eczema is very common. The standard kind of way of looking at it is that this is a cutaneous syndrome that is very chronic. It relapses, it's very itchy, and it is inflammation of the skin. It most frequently occurs in children, but can also affect adults, both children who grow into adults that continue to have persistent eczema, and it can also have its onset in adulthood too. It's often associated with elevated IgE levels, which means then it's an atopic disease, thus the name atopic dermatitis. Individuals with this either have a personal or family history of atrophy very often, and many times they demonstrate sensitization to environmental or food allergens. And we're going to spend a little bit of time talking about that specifically so that you have an idea how to manage that sensitization. And for the purpose of these talk, and most of our patients, they sort of use the word atopic dermatitis and eczema interchangeably, and we'll do that today, although technically eczema really is probably a bigger entity, and atopic dermatitis is a small subgroup of it, but we will use them interchangeably today. So what we want to look about first are what are the important components of atopic dermatitis, and there are genetic components. There are genetic changes that can make an individual more prone to atopic dermatitis. There certainly are changes in the immunology. The environment can affect it, and then we're going to talk a little bit more about barrier dysfunction. So what's the epidemiology? Well, the current statistics say that 20 25% of U.S. children may actually be affected by atopic dermatitis in some manner or another. And we think that the incidence of it seems to be increasing. There's a lot of different reasons why we think all allergic diseases are increasing, and that could be a whole nother hour lecture. But suffice to say that it may be changes in our microbiome and how we process different antigens may be part of it. Some of eczema may be also associated with changes in our external environment, and also changes in our epigenetics, or signals that we change in our immune system. There are worldwide about 31.6 million people in the US that have atopic dermatitis, and about 8 to 14% worldwide of the population also has atopic dermatitis, which you can see a much higher incidence in children. And oftentimes it presents before the age of 5. In fact, about 85% of kids who have eczema present before the age of 5. There is a slight difference in terms of female to male predominance, but not terribly impressive. And what we know is that in individuals who have atopic dermatitis, 30% of them develop food sensitization. So we've got to try and figure out, what does all that mean, the eczema and the food sensitization? Does that really mean food allergies? And we'll kind of come to that in just a few minutes. We know that 30% of kids who have a childhood eczema, they go on to persist to eczema in adulthood. But I think it's pretty encouraging that 70% of them do not continue to have eczema. We know that it's part of this thing called the allergic march. And what we see with the allergic march is that individuals start to develop eczema in the very first few months of life. And then as they turn on their IgE machinery and it gets much more efficient, then those individuals oftentimes go on to develop asthma, and oftentimes go on to develop allergic rhinitis also. And again, the numbers of children worldwide are very common. We also know that eczema has a big impact financially on our healthcare system. It has a significant cost burden to the U.S. In reports from 2017 from the National Eczema Association, $5.3 billion are spent per year for both indirect and direct costs for medical care in the U.S. And remember, direct costs are the things like the prescriptions and healthcare visits, and then indirect costs are things like missed days of school, or missed days of work, or lost productivity. And there was a survey done in 2015 that looked at families who had children with eczema, and they reported spending at a minimum about $250 to $300 a month just on eczema care in one form or another. So it can have a significant financial burden for families also. So what are the risk factors for developing eczema? Number one, atopy. 70% of patients who have a positive family history, so they're very much going to be associated with that hyper IgE machinery. We also know that another risk factor is a genetic risk factor, and that has to do with a gene called filaggrin. And filaggrin is very important in maintaining the barrier that we have in our skin that helps us keep the inside things inside and the outside things outside, but also helps us keep the moisture level in our skin. And we know that a very high percentage of patients, up to about 25 to 30% of individuals who have atopic dermatitis may have a filaggrin defect that makes them intrinsically genetically at high risk for developing atopic dermatitis. As I mentioned, there are lots of different theories on why we're seeing a lot more increase, and a very popular one that gets a lot of press on the Google searchers is the hygiene hypothesis. And again, the hygiene hypothesis has to do with what bacteria and how our immune system responds. And in short, what it says is that the more dirt you're exposed to, or the more pathogens, or the more diversity in your bacteria or microbiome that you have, then the less likely you are to develop atopic dermatitis or other allergic diseases for that matter. There are some other interesting things that have been shown to be risk factors. One of them has to do with how hard your water is. And there was a recent study that said in individuals that have really high calcium carbonate in their water is really hard, then that actually is associated with an increased prevalence of atopic dermatitis. And that could make good sense in terms of trying to get water in the skin and hold on to it also. And then the most common thing, which families are very much invested or have read a lot about, is they think that food is very much associated with atopic dermatitis. And there's been a lot of discussion about the timing of certain foods, when you introduce foods in terms of how old the infant is or the child is, or whether or not you have certain foods during pregnancy or whether you have certain foods during nursing. All of those things at one time or another have been studied and thought to play a role in the development of this IgE machinery that leads to atopic dermatitis. So, diagnosis, we've actually had criteria for diagnosing eczema for a very long time, and the major diagnosis criteria that most of us look for is it has to itch. There are sort of characteristic skin patterns that are associated with eczema or a specific morphology. And then eczema in most individuals has multiple different stages, including acute and subacute and chronic patches, all on the same child. And then there are certain patterns of distribution, which we'll go over, which are associated with eczema. And then again, the classic history for eczema is that it is chronic and that there are parts that stay, or there's this relapsing course that happens throughout the time period with their skin. There are some other things that support the diagnosis, again, being strongly allergic, specific dryness or xerosis is oftentimes associated. And then there's some other non-specific things that can also be found that we may see associated with eczema. Also, some of these findings we're going to see on the next few slides so you can see them specifically. But basically, if it doesn't itch, it probably isn't eczema. So, what are the clinical manifestations? As I mentioned, it's very dry skin, it's very itchy, and those are the hallmark symptoms of eczema. And you can see on this little guy here is some nice patches of eczema here on his face. The presentation is very variable, as I mentioned, depending upon the age. And we talked again about that there can be 3 stages. Acute eczema is characterized predominantly by redness, and they can be papules and vesicles, and they can be weeping and oozing, or they can be crusted. Subacute tends to be more dry and scaly, and chronic tends to be more like hinified or very thickened, kind of a little more like plaque-like, very chronic areas with fissuring, and that tends to, all 3 of these can be present at any one time on any patient. So let's just look at some of the morphology, and we'll just kind of characterize it. As a non-dermatologist, I like to describe things simply, but I want to put them in my medical record so that I want to describe the extensive areas, what I see, so that the next time I come back and see the patient, I may have some sort of a comparison. And so I do try to describe it in these particular terms. And this is helpful for me. I talk about the redness, what it looks like, how much it's been scratched or excoriated, and then how many areas are like hinified. So this is a scale that I think is very just useful for you to see visually. There's no magical way to describe it other than you can see that the erythema can get worse over time. And certainly when we look at erythema in skin of color, it can look very much more purplish or violaceous and not have as much of the red intensity to it. But erythema or erythematous areas usually are more diagnostic of more of an acute process. And then papulation has to do with the bumps of what you actually see. And you can see here in this slides that you can have some barely visible ones that you can only just palpate. But as they become more and more extensive, they come to the surface, and then they can become very well demarcated in some individuals, or kind of all run together in other individuals, and those papules are part of the eczema process. And one of the things that you probably have seen very commonly are what I call picker's nodules. These are prurigo nodules that are caused because of the repetitive scratching or picking at particular areas. And when it occurs with atopic dermatitis, it's very difficult to get individuals to stop scratching these because they are so very itchy. And then in the healing process, we see a lot of hyperpigmentation, so they can leave a scar for many, many years. So it is a very difficult process to treat. It involves a lot of very intensive treatment. And again, trying to break the itch-scratch cycle is very important in these individuals. So, and that leads me to the excoriation part, which again is breakage of the skin or areas where there can actually be leakage of the stuff on the inside getting to the outside. And what we see is that you can see extensive erosions, or even at times crusty areas as this progresses. And then the last thing that we oftentimes talk about when we describe eczema is lichenification. And that would be kind of these furrowing or linear markings that we see that happen as the skin becomes more and more thickened and drier and drier. And these are areas that you predominantly will see like on the elbows or the knees, or in more chronic areas that they may have scratched over and over time. So that's basically the way that I describe eczema. Let's talk just for a second about the distribution. The patterns do change, and part of it is a developmental thing based on what you can get to scratch. So in young infants, very young infants, we don't really see a lot of eczema on their feet or on their knees because they really can't reach down there and scratch so much. The distribution that we see more in infancy are in areas where they might be able to lift their head and scratch it on the sheets. So we see a lot of cheek involvement. We may see neck involvement too. Partly maybe because of maybe they drool in that area and it gets a lot of moisture, or their fabric is there. We also see it on the chest area. And then what we see in infants, it tends to be more on the extensor surfaces. So more on the outside of the arm than on the inside of the arm. So we see it on the elbows and knees more commonly as they start to age. But in really young infants, we may see a lot of it more in the head area and areas that they can get to scratch. So it usually spares the diaper area. And again, acute lesions in infancy can be all different stages. We see a lot of exudates and crusting in young infants also. And then as they age, we'll say 2 to 16-ish, the eczema seems to shift in its distribution, and we start to see lichenified areas more in a flexural distribution, especially in the antecubital and the popliteal areas behind the knees. And we also see a lot more on the volar aspects of the wrists and the ankles, and also in the neck area also. So, and these are just some examples of pictures that will show you, this is a very lichenified area here on the wrist. You can see very thickened areas, and this has some significant chronicity to it. This is a picture of a popliteal area where you can see some redness and induration there, and it tends to look to be a little more like a fresh area of eczema, maybe a subacute or a more acute pattern. And you can also see on this little girl some areas of eczema, and she's doing what most individuals with eczema do, which is scratch and scratch. And then as we shift more to adult patterns of eczema, it becomes more localized and over time becomes more lichenified. Again, these areas that are involved are oftentimes more in the flexure areas, and less frequently in adults, the dermatitis involves the face or the neck, but can sometimes still involve the hands, but less frequently the hands unless they have a concurrent hand dermatitis. So, eczema is very problematic. It really affects the quality of life for many, many individuals. Not only can it involve multiple areas of the body, but it also affects their quality of life, and we know that the actual total numbers of days during the year that they have acute symptoms of eczema is about 40% of the year. So this is a very chronic problem that goes on for them and relapses. Most of them, as I mentioned, demonstrate eosinophilia, and with that, they also have elevated IgE levels. And commonly, though, the axilla, the gluteal area, and the groin area are oftentimes spared in individuals who have eczema. So what's your differential diagnosis? There's a whole lot of things that can look like atopic dermatitis or eczema. There's certainly contact reactions that can be both irritant and allergic. Seborrheic dermatitis sometimes can look a little like eczema. There's nummular eczema that tends to be eczema that's more in circles that we see on the body. Certainly psoriasis has been confused with eczema. Scabies is another one I remember very well when I was a fellow and I saw a child newly and he was diagnosed with eczema and we were treating him with multiple steroid creams and we kept bringing him back several times and he just didn't seem to get a lot better, and I was very frustrated, you know, and I felt like they were compliant with what I'd asked them to do. And then somewhere about the 6-month mark, mom brought in the sibling and she said, oh look, his 10-year-old sister suddenly has eczema too. And I thought, 10-year-olds don't usually just suddenly get eczema that's so significant. And sure enough, when we started looking between the fingers and, you know, did a scraping, it was scabies. And scabies looks very different once you've already applied topical steroid creams to it. So I always try to back up and think, could this be scabies? And it makes me think of it more when it's sort of an acute onset of eczema. But there are drug reactions. I'm sure everyone has many stories of things that they thought of that might have been eczema that ended up not being really eczema. And we also know that zinc deficiency can also complicate eczema and also be a presentation of atopic dermatitis also. Then there's the rare stuff, and I could say that I have seen some of these. I don't really go looking for them. They sort of find their way to me, and so they kind of stay in the back of my mind. I have had a couple of skids that had graft versus host disease that initially was thought to be atopic dermatitis. I've had in my career at least one omen, which is a significant immunodeficiency also, that was initially called atopic dermatitis for about 12 months until we had some immunological studies and realized that it was not atopic dermatitis based on some other presentations. So these are the associated features that I like pictures, so I put in lots of pictures so you can see some of the other things that go along with atopic dermatitis or the presentations that you see. In skin of color, we can see some central pallor and clearing over the cheek areas and also in the nasal bridge area. Keratosis pilaris, you're going to see very commonly in individuals that have atopic dermatitis. I call this chicken skin. These are those little bumps that oftentimes are in the triceps area. They're not necessarily always with eczema, but they commonly go along with it. And it's sort of a soft type of eczema. Although we usually don't treat these a lot with topical steroid creams, that doesn't seem to be very effective. And I'm sure the dermatologist probably would be, maybe she covers it in her slides. I haven't seen her most recent lecture, but we usually use things that will kind of slough the skin more in those particular things. So like a salicylic acid or a good moisturizer for KP in the allergy world. We also can see white dermatographism, which means that when you scratch the skin, what you actually see is a wheal instead of just redness. And that goes along very commonly with atopic dermatitis. And then when you look at the palms of individuals who have eczema, they oftentimes have tons and tons of lines due to the excessive dryness of their palms. So that hyperlinearity oftentimes goes along with atopic dermatitis too. And so these would be features that might help support your diagnosis of atopic dermatitis. Some other features that we oftentimes see is this pityriasis alba. This is a loss of pigmentation, not completely, but just kind of more lighter area of pigmentations that we might see in skin of color. We also see sometimes because of chronic rubbing and scratching, loss of the outer part of the eyebrow. And then this is pretty common in young kids. This is this auricular fissuring where the skin actually gets broken because they have trauma and scratching at their earlobe. And then also we can see classic Denny-Morgan lines. Those are not unique just to eczema, but they're sort of a marker indicator more of being an allergic individual. And we see those a lot more frequently. And then also we can see darkening of the periorbital area also as a feature associated with eczema. So there are some other clinical variants. We oftentimes see kids who have significant eyelid disease also, where they may have done a lot of rubbing. We also see other types of eczema that can give you eyelids in isolation, but oftentimes with more total body or more larger areas of eczema, we will see eyelid dermatitis. And this picture also demonstrates for you again Denny-Morgan lines, which are these extra folds that are under the eye in individuals who are allergic. And then we can also see breakdown of areas around the mouth, and lip eczema can be very common. It can be very dry, and oftentimes because it's so dry, individuals will pick at their lips a lot, and so that may cause them to be more cracked and fissured, and it can be very painful and disfiguring for lots of individuals. So again, what I stressed, which was super important, was the fact that this itch-scratch cycle sort of continues to propagate the eczema process. So when I was in my early training, the discussion always is that eczema is the itch that rashes, and the itch comes first, and because it's such a unable to be controlled itch, that because you continue to scratch, you cause trauma to the skin, and that trauma breaks down the skin and leads to eczema. What we know is very important to understand about the itch of eczema is that it is not mediated through histamine fibers. What we know is that there are different cytokines that seem to play a more important role in the chronic itch. And so because of that, antihistamines, unless they are being used for a sedation effect, really don't have a huge effect on the scratch itch cycle. And again, as I said, the more we scratch, the more skin trauma we have, the more excoriation. That leads the keratinocytes to release their cytokines and to amplify the inflammatory process. So it's very important that we try to get at the itch, but not so easy. So let's spend just a minute and talk about the pathogenesis of atopic dermatitis. And I call this Mike's kind of inside-out hypothesis or theory of understanding it. There are things from the outside that are important to acknowledge and understand when we're thinking about the pathogenesis of eczema. And then there are things from the inside that lead to the development of eczema also. So the most important thing to understand initially is the outside or the skin barrier. And what we understand more and more about atopic dermatitis is that this skin barrier is critical to try not only to heal eczema, but also it is probably one of the main reasons why we develop eczema. And so the skin is, your first line of defense between the body and the environment. It keeps irritants out, it keeps allergens out, it keeps different bacteria and viruses out, and it also prevents water loss from the inside. And so having an intact barrier is very important. And the barrier function is in this top layer, the stratum corneum. And we mentioned just a little bit earlier about the filaggrin gene. We know that mutations in the filaggrin gene actually cause a disruption in this barrier, and so we're not able to hold on to water as well. And that's again been shown to be a very significant genetic risk factor for the development of eczema. And when you don't have a good barrier, then all the things we want to keep out have the opportunity to come in, and then we get inflammation and disruption more of the barrier, and we also then continue to have transepithelial water loss, which is the major issue for patients who have atopic dermatitis, along with the inflammation. So we know that, as I mentioned, this transepithelial water loss is very important. And we also know that how well the skin cells stay together and how well they lay down can be very important. And there are different chemicals in the skin that help us keep our skin kind of glued down. And some of those are lipids that are present. These are the ceramides, the cholesterol, the fatty acid, and all of those things are there to try to help keep the skin cells tight together and hold them in a good position so they can keep an intact barrier. And what we know is that changes to that can obviously lead to the inflammation and water loss. And so, as I mentioned, filaggrin is important, and then also the more water loss that you have, the oftentimes greater disease severity that we have. So the important kind of take-home points about the barrier is the water loss, and by having a disrupted barrier, it gives the opportunity for allergens to penetrate the skin and have an easier opportunity to cause inflammation and inflammatory process, but also allergic process at the same time. And that'll be important as we start to talk about ways to treat eczema. So then the inside out part of it has to do with defects in our immunity and in our immune system, and also our adaptive response to those things. And so I just want to take, this is the one slide on immunology that just sort of looks at both parts of the immune system that we're thinking about. And the reason why this is important, because we have new therapies that are being developed. Some of them are biologically targeted therapies that actually look and deal with some of these parts of our immune system. So just to kind of remind you, remember we have our innate immune system. That's sort of what we're born with. It's very short-lived. It doesn't have memory. And it's the things that help us defend ourselves from day one, and that is things like our physical barrier. There are also different microbial peptides that are present in the skin that can identify different pathogens. There are also some antigen-presenting cells that sort of scoop up and recognize foreign things that they have no memory for, but they know to pick up those things and try and get rid of them. And then our normal flora of our skin is very important. When we're populated with good bacteria, then we keep away the bad guys. And there are different receptors and pattern receptors that are present in association with that flora that help us maintain a good immune response. And they talk and help maintain the adaptive immune response. And so the adaptive immune response is our memory response system. That's very long lasting. The more and more things we see, we develop memory. It has specificity, and it is largely run by antigen presenting cells that are in the skin, and also B and T lymphocytes, and what patterns of cytokines that they release. And in general, in atopic dermatitis, it tends to be a very Th2 or allergy-driven kind of model, although Th22 cytokines, which are sort of less specific for allergy, can also be involved. And these are the cytokines that are listed here that are very common, and the IL-4 and IL-13 are cytokines that are important in the Th2 response. And then there's also something called TSLP, which is another cytokine that is important in the barrier defect. And the reason why I mention it is because there's a new biologic that is being developed that actually helps at this particular level in the immune system. So long and short, our skin is very good at protecting itself when it's working well, and it also is good at making memory to the invaders that come along to try and help protect itself, but it's also very susceptible to allergens. So what are our treatment goals for atopic dermatitis? Well, our goals are obviously we want their skin to get better. And the ways that we want that to happen, we want to reduce the symptoms, not only what we see, the inflammation, but we'd also like to be able to address the itch. We'd like to be able to prevent exacerbations, and whatever medicines that we pick, we'd like for them to be simple and understandable and have very few therapeutic risks. So the kind of multi-prong approach that I use is I try to figure out if there's anything that's exacerbating the eczema that I might be able to reduce. Then I spend a lot of time thinking about restoring the skin barrier function, and then obviously patient education is very critical, that they understand what they're to do and what they're to do at home if they have a flare, and so that they feel in control of their management. And a lot of that does in fact involve some pharmacological management of the inflammation. So here's sort of my approach again to treatment. I respect the skin barrier. I think it's very, very important that we try to protect it. And so it's important to think about things like what soaps or detergents that we might use on the skin. There's a lot of thinking that some of the soaps that we might use may disrupt some of those lipids that are present in the skin, like the ceramides. So if you sort of break down those lipids because you're using a harsh soap, then obviously the glue that sort of helps hold the skin together better is going to be disrupted. So we really oftentimes in patients who have eczema even use soap-free cleansers so that we're able to protect the lipid layer of the skin better. We want to do everything we can to restore the skin barrier. So that has a lot to do with bathing and trapping the water and trying to put some sort of a barrier so that we don't have transepithelial water loss. And then for the inflammation that's there, we want to use anti-inflammatory things, and we're going to talk about a few of those that will try to reduce the inflammation that's present. And then what's equally important is oftentimes we have to think about helping with sleep, because these individuals are very much having problems trying to sleep because they're itching and scratching so much, and it disrupts everyone's lifestyle whenever you have an infant or a child who can't sleep because their skin is bothering them so much. And then education, and again, reducing the exacerbating factors. So what about bathing? So I can tell you I've heard 29 different people have 49 different opinions about bathing and whether you should bathe every 3 days or every 1 day or never bathe. And I sort of, as an allergist in reviewing the literature, at least in our neck of the woods, the allergy neck of the woods, we have come to the decision, and I've come to the decision, that probably hydrating the skin every day is important. So I recommend to my patients that they have a daily bath. I don't think that the number of minutes that they're in the bath and whether or not there's a timer and whether or not they put a thermometer in the bathtub and the temperature is exactly this degrees is nearly as important as the fact that they soak and they hydrate and get the water in their skin, and then we trap it. So ideally, bathing is better, but if I have individuals who are showering teenagers and they're not about to get in the bathtub, then I'll take a shower, because water of some exposure is better than no water exposure. And again, as I mentioned, we try to do soap-free cleansers and detergent-free cleansers and shampoo if we can. Again, those harsh soaps can be very disruptive to the skin barrier. And even we got asked earlier in the questions section about whether or not to add baking soda or oatmeal to the bath. I really think those can be drying, so we don't usually add those to the bath. It's important to know that soap has a very high pH, and that can really disrupt the pH of the skin also. So it can be a significant irritant, not only just disrupting the lipid layer. So that's, as I mentioned, bathing is very important. It's also important that we try to find a cleanser that does not have sodium lauryl sulfate. That in particular can be a chemical that is very much an irritant for kids with eczema. So we usually try to find products that don't have that. And I've listed here on the slide, you can come back to them, multiple different ones that are available at most of the places where you might buy cleansers. There's several examples there of non-soap cleansers. And I really don't have a preference one way or another, other than, they should find one they're comfortable with and continue to use it. And then, as we mentioned about the question of adding additional things to the bathtub, there's really a lack of high quality studies that provide evidence of benefit. I know that the American Academy of Allergy, Asthma, and Immunology, and their practice parameter, they say that you can use some bath additives, and the American Academy of Dermatology recommend against it. So again, you're going to find opinions one way or another. The most important thing for me is that they get in the bath, and if mom really feels like that if she sprinkles a little bit of oatmeal in there or an oatmeal bath product and they're going to stay in the bath and get their skin hydrated, then I'll take that as a trade-off. Again, as long as when they get out of the bath, we're going to trap the water. So that brings us to our next step, and that is we want them to barely pat dry, and you want them to dry off only enough so that the hydrating moisturizer, the emollients, can stick. So it really is a very light tap at best in order to get whatever you're going to put to try and seal the moisture in. And so let's talk about what do we put to try and seal the moisture. So again, the hydration is the key component, and there are differences between lotions and ointments and creams, and basically they have to do with how much water is in the product. And so if you buy something that's a lotion, the number one ingredient on that particular bottle is going to be water. And so you are sort of adding to the opportunity to get some evaporation when you apply that to skin. Better things are ointments, which are the kind that you would stick your hand into and oftentimes looks like Vaseline. And there are lots of individuals who even like Vaseline in and of itself as an opportunity to seal that water and to get a barrier. Vaseline in and of itself does not actually add moisture, but does in fact add a protective barrier though. And so what we say basically is that you should apply something to the skin at least twice a day, and certainly immediate after bathing. And if they're doing hand washing, it's also good to have a little hand cream or ointment available that they can put on their hands immediately. And then there's a lot of discussion about ceramides, and do you need to put ceramides additionally in whatever product that they're using. And there are certain brands that are available over the counter that are very popular because of the ceramides. And in general, ceramides are important in what we see in the lipid layer of the epidermal barrier, but we're only temporarily putting them back when we use a ceramide. There may be some benefit in some individuals, and there's certainly individuals who swear by them and think they're wonderful. And again, if they like the product that they're using, then I'm all for it because they're going to apply it and use it more. Whether or not there is a ton of evidence that says ceramides in your lotion gives you a wealth of benefit, there really isn't. There's a couple good studies that say there may be some benefit from it, but there's not an overwhelming amount of evidence. But they're certainly not harmful for most individuals. So again, whatever they pick is most important, and I go along with it. So what about kind of standard treatment? Again, as I mentioned, I have them do a daily bath. Then we have them use soap-free cleanser, and then barely pat dry, and then apply their topical medications, and then also their cream or ointment-based moisturizer. And as I mentioned again, Vaseline is very good for occluding the water that you're trapping, but most individuals feel it doesn't actually count as a moisturizer. So what do you need to know about the hydration? So again, as I mentioned, hydrating is the most important thing for me. There was a recent systematic review of about 77 studies that looked at kids and adults who had mild to moderate eczema, and it looked at the efficacy of different emollients and moisturizers in reducing the signs and symptoms of eczema and the frequency of flares. And ultimately what this systematic review said is that any moisturizer, if it's used, is really the best. And so there was no one particular brand that was associated more with eczema severity reduction or decreased itch. The most important thing is that you use a moisturizer, but you're still probably in most individuals going to need a topical steroid cream to help address the inflammation if you have moderate to severe eczema. So I find it very helpful to try and address the severity of the eczema because in addressing the severity of eczema, not only do I kind of know from one visit to the next how they are and whether or not they're doing better, but in addition to that, some of the new therapies that we're able to use, the biologicals that patients get for their eczema are based on their severity scales. And so there's a lot of different scales that are available. Some of them are a little complicated, and I try to, again, keep things as simple as possible for me. So you may see, if you're reading a paper from a dermatology group, that they may have used a SCORAD index, which looks at, multiple different things, not only the different stages of eczema, but also the extent of the body that was involved. And actually there's even an app you can download to your phone that has some of these eczema scoring scales on them, and you can use your phone in the room and sort of score it out and give yourself an eczema score that you could put into the chart. One of the ones that we like to use that is very helpful is actually a POEM score. And the POEM score stands for Patient-Oriented Eczema Measure. And this particular scale we give to our patients as they're, waiting for me to come into the room, or maybe they're filling out paperwork or whatever. And that sort of helps me assess the severity of their eczema. And this is what the POEM score looks like. And it's really easy. And I put the notation, one of them here on the bottom of this slide that you could come back to and think about downloading this particular the scoring scale. We like to use a lot of different ones. I think it sort of adds to us in the EMR also noting that, we did a thorough exam and had some more complexity to the visit than just, commenting about how, the eczema was good or the eczema was, problematic. And this POEM score, basically what it does is it has the adults and the children rate how their eczema has been over the last week or so. And so as you can see here, it asks us questions about, is it itchy? Has their sleep been disturbed? Have they had a lot of bleeding or oozing from their skin? Is it cracked, flaking? Is it dry or rough? And much like the ACT that you might use in your patients that have asthma, this scale, this particular questionnaire and the scale for understanding it sort of can be a jumping off point also with your families, that they can understand what's going on and they might be able to discuss it further. And that makes it a little bit easier too for them to talk about their eczema because they just answered this questionnaire. So we do POEM scores in most of our patients and find it pretty helpful. But basically when you're thinking about how severe is the eczema, you want to know a little bit about whether you've got mild disease or moderate disease or severe disease. Again, is it just a little bit of an area that doesn't impact them much at all? Or is it a bigger area, but it's not weeping and oozing? Or is it more widespread and they've got cracked and bleeding areas that are significantly impacting them and their quality of life? Any type of eczema, though, can in fact affect the quality of life for most individuals who have it, mostly because not only is it at times disfiguring or not attractive to the individual, or they don't feel like it's attractive, but also because of the itch. The itch can just be overwhelmingly a problem for many individuals. So I think that the psychosocial component of eczema is probably very much undertreated and not discussed enough in our care of patients. So, but I like this particular table. This is from Up to Date, and they basically talk about step-up management. It's also from Dr. Buganowitz. I never say his name quite right. And it was recently published in the Annals. And it basically says there's some things we should do for all patients that have eczema. And then as their eczema gets worse, then we step up to this therapy. And then as their eczema gets a little bit worse, then we step up to this therapy. So, and basically in all patients who have eczema, they should be doing the daily bath, and they should also be trapping the moisture as easily as they can by putting that on very quickly. And then if there's particular triggers that have been associated with eczema, we want to try to address those. And then there are some things that we can do if they start to have secondary staph issues. That may be a bleach bath or antibiotics, which we'll talk about in just a minute. Again, though, the same basic skincare and also trying to avoid triggers. And then as they get more moderate, then we apply topical anti-inflammatory medications, and that can include several different products, including steroids or tacrolimus or Eucrisa or crisaborole, which we'll talk about in just a second. So, and then in the acute phase, we apply the topical steroid cream to the inflamed skin. And then as they become more and more involved, at least by this paradigm, then sometimes we'll increase either to cover more areas or potentially increase the potency in order to try and bring down the inflammation. And in general, I don't tend to taper. I tend to treat until I don't feel it or see it, and then I feel okay to go ahead and stop the topical steroid cream. If they don't respond to therapy, then you need to consider whether or not we have a misdiagnosis, or whether or not there's secondary infection, or possibly that they're non-adherent to the regimen. Maybe we made it too hard, or maybe they weren't able to get the medications that we had prescribed, and we need to double back. I think what's really important, and here is sort of what the atopic dermatitis yardstick looks like from an allergy immunology standpoint, is that, again, it's this basic skincare, addressing the triggers, and then you add the topical agents that are used for anti-inflammatory. And then if you still can't get them under control, then they need a referral either to the dermatologist or to the allergist for additional therapies. And that because it's a chronic illness, you step up for a little bit and you step down when they're doing better. And that's sort of the way that it's recommended to approach it. So what is your guidance for topical steroid therapy? So a lot of individuals, the first thing that you need to acknowledge is that people are afraid of steroids. And so you need to say that up front, and I'm here to answer your questions, to discuss them. There are so many misnotions that are all over the internet, or they hear from their grandmother. And if you don't sort of deal with the elephant in the room, then they're going to be hesitant to use the anti-inflammatory medications that they use. When I'm picking a steroid cream, I often think about what location, whether or not they're going to be using it for a long period of time. Is the skin really lichenified? Am I going to have a hard time getting the steroid to penetrate that area? What's the cheapest one that they can afford or have access to? And then also, we want to make sure that they feel comfortable enough with the medication to use it effectively. And again, the steroid creams are most effective when they're applied after a bath within about 3 minutes. So I tell my families that I want them to put it on within a minute so that they get the urgency of it, and they're more likely to get it there so that we can trap it. I know that Miriam has a lecture that's in the recorded group that talks about how she selects topical steroid creams, and there are so many different ones that are available on the market. And in general, I think as a practical point, I sort of have like 2 or 3 that are my go-to, that I like and that I use. And certainly understanding the relative class and potency is very important. And then understanding which vehicle you want to use, whether it's a cream for certain areas or an ointment in general. Again, ointments we think are probably preferable in patients that have atopic dermatitis. Which one you pick is probably going to mostly depend upon how much of it can you give them and what their insurance is going to pay for, and then you sort of remember the relative class understanding of those medications. Which brings me to my next point is how much steroid do you actually need to prescribe? I have lots of patients that come to me that have head-to-toe eczema, and they've been given a 30-gram tube of something that they're allowed to renew every 30 days. And that's really not going to cut it. So I think it's kind of important if you think about how much body surface area do you need to cover with the steroid in order for them to be able to get adequate anti-inflammatory treatment. So what we oftentimes do is we sort of think about fingertip units. And a fingertip unit is the amount of topical steroid cream that you would squeeze to go from the first mark here on your finger to the tip of your finger. And a fingertip is considered the amount of steroid cream that you would need to treat an area of skin twice the size of the palms of your hand. So if you had an area that was like from here to here on your arm, then that's at least 2 hands worth. So that would be 1 fingertip unit. And 1 fingertip unit is equal to about 1/2 gram of topical steroid cream. So you could see that if you needed 2 fingertip units, then that's about 4 adult hands, and that equals about 1 gram or so of steroid. And in general, depending upon whether it spreads easily, but that's roughly about where it is. And so if you had someone that needed to use this particular size area of skin that were 4 adult hands, then what you would see is that that 30-gram tube of medication would be gone in about 15 days. So it wouldn't be enough to cover large areas of skin. You're not giving them enough steroid. So they're already kind of behind the 8 ball, and they're not going to get a lot better because they don't have the anti-inflammatory medication that they need. So the take-home point that I would have here for you is that it's important that you prescribe enough steroid cream that they can cover the areas that they're dealing with. Now, the question that they're all going to come back again is their fear of the steroid cream, and everyone is afraid. Someone told them that if you use steroid creams on the skin, then you can see atrophy or thinning of the skin. But that all depends, again, on the potency of steroid cream that you're using. And certainly, oftentimes, when we are using steroid creams for eczema, we may be using very moderate to mild potency depending upon the area. It also depends on whether or not it's occluded. We also know that steroid cream that's occluded does have deeper penetration and a little more absorption. But in general, I don't really worry about atrophy per se if I'm treating the inflammation of eczema appropriately, unless we are using it on skin over and over again that's too high of potency. Then we think about thinning of the skin. Thinning of the skin really happens more in older patients and using the higher potency. So, and the other thing that they worry about is it's going to make my child short or whatever other side effects they may have read about topical steroid creams. And I reassure them that systemic effects for topical steroid creams are rare. They do occur sometimes, but they're much less frequent than what probably is being said out there in discussion of other families that talk about steroids. So you have to talk about it because they're worried about it. And we really don't see HPA axis suppression in general in people who are doing steroid creams appropriately. So one of the other medicines that we have are topical calcineurin inhibitors. These particular are non-steroid anti-inflammatory agents that can be used in eczema. They decrease T-cell activity and the inflammatory mediator release from the T-cells. They can be very similar to a mid-potent topical steroid cream, and they can be used easily on trunk and extremities in adults. It also can be used on the face and neck in individuals that you're worried about using steroid creams on too, or if you have steroid phobic parents. So it can be very burning though, so some individuals, especially if the skin is really excoriated, they may not like these particular agents, or you might have to tell them to use it a little bit at a time until they kind of get used to the little bit of a burning sensation. But they can be very helpful. Some time ago, there was like an overabundance of writing of of Elidel or the pimecrolimus, and there was some concerns about whether or not there was increased risk for lymphoma. And actually, that's been well studied and discussed now in the literature, that really is not an appropriate concern at this time. So in general, we don't use these agents though in children under 2, and you don't want to use it at the same time if it's a patient who's getting phototherapy, because you can have more burning and some more difficulty with those products. And then you want to also make sure that if they are going out in the sun, that they use appropriate sunscreens, or better yet, don't go out in the sun that much, or make sure that their skin is well covered. So we talked about in the discussion before this lecture about Eucrisa, which is a new product that is available on the market. It's a PDE4 inhibitor, and it's very popular because it's a non-steroidal anti-inflammatory medication that has been shown to decrease severity and itching in patients who have atopic dermatitis, and it can be very effective, especially in patients who are worried about steroids again. There is a little bit of burning and stinging that can also occur at the site, but it can very much be a first-line agent in patients who have mild to moderate atopic dermatitis. And there is really no concerns about the duration of the use of this particular product. It's not terribly hard to get it approved. Sometimes I do have to get a prior authorization on a couple insurance plans, but it's not that challenging. And then we come to the severe eczema. I may pause here for just 1 second. Is there any questions that have come in on what we've covered so far as we move on to severe that I need to pause a moment for? Joe, do you have anything that's come in on anything we've talked about so far?
Dr. Hogan, there's actually a number of questions.
Okay.
So I'm not sure if you would prefer to just wrap up your talk and then go to questions, or maybe take some questions now and then go back to your talk. You let me know.
So there's a lot of questions?
There are.
Okay, well, let me roll then for just a little bit, and maybe
Yeah.
we'll have several minutes at the end to hit the questions. Okay.
That's good.
So, so the severe atopic dermatitis patient is very challenging, and they can have areas that are very mild and also moderate areas, or they can have extensive body disease and have a significant impact on the quality of their life. There is unremitting itching, and they oftentimes don't seem to respond to the topical steroid therapies that we've prescribed. And so when you have a patient that has severe atopic dermatitis and extensive body disease, I usually go back and make sure, yes, do I in fact have the correct diagnosis? Is it a treatment failure because I made it too hard and the family is really struggling on figuring out what to use where and when, and can I simplify that? Oftentimes there are multiple people that are participating. You know, maybe they went to urgent care, maybe they've seen 3 different providers in their home primary location of their primary care provider, and maybe everyone has a little bit of a different view on how to do things, so they've heard so many different ways they can't keep them all straight. Maybe they didn't get adequate instructions. Maybe they were so overwhelmed by all of it that they just weren't able to listen. So I always try to make sure that I give them written handouts. The National Eczema Association, which I'll show you in a second, has great handouts, so I oftentimes will refer them to that website and also give them some of those handouts. And then again, the fear is a real concern, so we have to address that. And then obviously in today's day and age of costs, we need to make sure that we pick the right one that was on their formulary, or that it didn't go off formulary last week. And we need to also, a lot of pharmacies don't carry all the medications. There is a particular topical oil that I like to use in babies, and I struggle a lot with trying to get it either approved or available at the pharmacies that I like to use it at. And then also there are other factors that worsen the eczema, things like irritants, infection, the allergens, and they may just be individuals that are going to have severe disease. So the first thing that I want to mention first are wet wraps. We use some wet wraps in our practice to try and really do a focused treatment in an area that is very problematic. And as you may know, with wet wraps, what you basically do is you hydrate the skin, and then you apply your steroid cream very quickly, and then you occlude it with some sort of a dressing that has additional moisture in it, and then you sort of put something on it to hold it in place, and then you try to leave it in place for as many hours as you can or overnight in order to have the steroid cream have a chance to penetrate a little bit deeper into the area. And so oftentimes I'll find myself doing wet wraps like on the wrist or maybe on the knees or the ankles in these very lichenified, thickened areas. So I often use Curlex, which is kind of gauze on a roll. And what I do is I tell the family I kind of want to mummy that area, so I may wrap it multiple times with the moist gauze and then try to hold it in place. And I oftentimes will use spandex. And so I'll have families go to Walmart and buy a particular spandex shirt and cut the sleeves off and make me some spandex dressing holders that will hold the Curlex in place if I'm doing particular areas. There's 101 different ways to use it. Some people use socks. I don't tend to use ace bandages because I worry a little bit that I might get them on too tight. Some people use saran wrap, but any any child could remove the saran wrap very quickly. So you have to think of some way to be able to hold that dressing in place. In this particular slide here is an example of a baby in our practice who had a lot of facial eczema that we weren't able to get at. And we went heavy duty on the wet wrap and actually used this particular dressing. And then we're able to put this stretchy knit material over the top of the head and for overnight sleeping. And actually, after a couple of days, we saw significant improvement in the atopic dermatitis that was on the cheeks of the face. So there we go. And so those are how wet wraps work. This is a handout from the National Eczema Association, which again instructs families on how to do wet wraps. And you can see here in this picture, this individual has wet wraps on the arms, and also in this particular case, this child has more extensive wet wraps on the ears and neck area also. Usually I don't do big body areas at one time. Because I think it can be a little bit overwhelming for the family. I usually try to hit the problematic areas, but you can do more extensive areas. And there are some people who do double pajamas. So they'll put on the moisturizer, they'll put some really tight fitting cotton pajamas on that they will spray down with a little bit of water and then put a zippered pajama on top of it so that they don't get cold. And I've seen that done many different ways by different individuals. There are some second line therapies that are available for eczema. We have a very great relationship with our pediatric dermatologists and share a lot of patients. Sometimes they will do phototherapy in patients that are able to get to the office 3 times a week, and that can help improve the atopic dermatitis. Sometimes we have patients with such severe disease we need to use some immunosuppressive agents. So sometimes we'll use cyclosporin, although not with a great deal of regularity. If we don't use cyclosporin, we may use methotrexate. I've used that in a few patients. I also have used azathioprine or MMF in some individuals. The most important thing when you have severe eczema is we don't want to keep doing oral steroids. And in fact, it would be my preference to not do oral steroids at all if I could keep from it. And I discourage that, obviously, because there's a lot of side effects that can go along with oral steroids. So in this day and age, we are so lucky. There is a new monoclonal antibody, dupilumab, that's available in individuals who have severe eczema that is very effective and is very helpful in trying to help control the itch and reduce the inflammation of eczema. The medication dupilumab is an anti-IL-4 receptor antibody. It inhibits a couple of the important cytokines that drive the T cell of eczema. It's approved by the FDA for treatment in eczema in kids who are 6 and up if they have moderate to severe disease and they're not adequately controlled with topical steroid creams. The FDA has also approved it for asthma. So in some kids, I get the opportunity to hit both asthma and eczema. It's been associated with improvement in itching significantly, also improves sleep, it improves quality of life measures. It really is a game changer, and there are more biologics that are coming. So if you have patients that have moderate to severe eczema that's extremely hard to make any kind of an impact, these are the patients for sure that I would want to refer to dermatology or to allergy so that we can use these monoclonal antibodies. And we have lots of kids. I'd say we probably have 70 kids at this moment that are on dupilumab. It's dosed. It is an injection. They can do it at home in older kids. And the most common side effect includes injection site reactions. There's a little bit of pain at the site of the reaction. And then sometimes we also see there's a conjunctivitis that can be associated with it. And so we sort of watch for that. And then it is also sometimes associated with an increase in cold sores on the mouth or the lips. But it is an excellent biologic that is making a lot of improvement for kids with severe eczema. So let's touch just for a second on quality of life. As I mentioned, these are oftentimes very fussy children or older children and young adults too, because they're scratching, their skin bothers them, they're burdened by the redness and the scaling, and it's very important to know that eczema can actually limit their lifestyle. 40% of them actually avoid social interactions because of their eczema, and this can lead to depression or anxiety. There's also some studies that have shown that it can even lead to suicide ideation and attempted suicide in individuals who have significant eczema and feel the burden of the disease. So I think it's important that we try to optimize therapy and also address some of the psychological components that come along with it. So how do we control the itch? Well, as I mentioned, antihistamines don't seem to do much unless you really sedate them. So sedating antihistamines that we have used sometimes are Benadryl. Doxepin is a particularly good one. It has a high ability to sedate. And also, as I mentioned, second generation antihistamines really don't have much effect because they are non-sedating and they don't help with the itch. Topical calcineurin inhibitors can be very effective in controlling the itch, but the most common thing that I do is I usually, if they're just clawing at themselves, is I tell the parent to go put them back in the bathtub, and the hydration of the skin again and the cooling of the bath can help temporarily relieve the itching. And then there are some creams that are available over the counter. I know Aveeno makes one. I know that Gold Bond makes one. I know that Eucerin makes one that actually have some anti-itch ingredients that in a particularly acute setting can be put on and be somewhat soothing or disrupt sort of the signal to want to scratch. We do have to mention that sleep disruption is very important, and again, we want to optimize sleep hygiene. Wet wraps can be helpful. There's also a study or two that show melatonin can actually be helpful in helping kids with eczema to also sleep. We want to make sure that we cover as much skin as we can without making them sweat too much. By covering the skin, they can't get at it to scratch as much either. And then we need to address secondary infection. It's very important to remember that Staph aureus is on our skin, but it also can get very high levels or super infection or super colonization, and that this relationship between staph and the eczema inflammation is associated with the more staph and heavier colonization can be associated with more severe disease. In this particular picture, you can see that the crusting and kind of golden part of it, or it may actually even be oozing, are indicators that there can be a lot of staph. If it's just a localized area, we oftentimes use mupirocin, but if it's more an extensive area, you may need to use an antibiotic for a couple of weeks to help decrease the staph colonization. And then sometimes that brings up, how else can we decrease staph? And that may possibly be through bleach baths. And what we know is that liquid chlorine bleach actually has activity against Staph aureus. And usually what we recommend is about a half a cup of bleach for a full bathtub, or a fourth a cup for a half a bath. And that is used in addition to our other agents that we are using for the skin, but that can help reduce the Staph aureus load and improve symptoms. There is a meta-analysis, however, that said that it really isn't anything magical about the bleach, probably as much as it is the bath that is equally as effective. And I think there are some patients who do better with bleach baths, so we do recommend it in patients who have significant open weeping areas. That may be something to think about. Parents want to be proactive. They want to feel like they're doing all they can. We know they're inexpensive, they're well tolerated, and they don't have adverse effects. We're essentially making a swimming pool by adding the liquid chlorine bleach. And there's also some studies that demonstrate that it has some anti-inflammatory effects in the keratinocytes. So let's talk for just a minute about the role of allergy. So we know that allergy oftentimes runs hand in hand with atopic dermatitis, that up to 80% of children with eczema develop asthma, and that infants and children are more commonly sensitized to foods, but sensitization does not equal clinical disease. And a very high percentage of them will have sensitization, but only about 10% of them will actually get urticaria from the food they're sensitized to. So we're going to have a very high prevalence of overdiagnosis of food allergy if we do the wrong test and we overinterpret it. So let's just spend 1 second as to why we think food becomes an allergen, and it may have to do with the mode of presentation. If you have exposure to the food through the GI tract when the GI system is more immature and kind of sleepy, and you present these antigens, then you're much less likely to develop IgE antibodies to those foods. But if the foods are presented through inflamed skin, then we think the antigen presenting cells in the skin actually process the antigen differently and are more likely to have you generate IgE antibodies. So it's this sort of dual hypothesis about which way the exposure happens of whether or not you're more likely to become allergic to that particular food. And so it's important that we address food, because parents come to you and they immediately say, oh, I've heard food allergy causes eczema. I want to know everything they're allergic to because I want to take all those foods out of the diet. And I've literally had patients come into my clinic and say, I want you to test them to every food in order to find out what they're allergic to. And we really have to back up again and say, we're not talking about allergy here, we're talking about sensitization, and we have to put it in perspective and try to decide whether or not there's any role for food allergy in the severity or longevity of this particular eczema in this child. So again, as I mentioned, sensitization is very high, but actual confirmed food allergy is much lower. And actually there's new data that shows the concern for food allergy is way out of proportion for what actually is the actual risk for food allergy contributing to atopic dermatitis. So the question comes up, do you need to send in for skin testing? Do they even have enough clear skin that you might be able to skin test? Or do you need to do a blood test? When do you test? What do you test? And all of those things are very confusing. If we go to the 2012 atopic dermatitis practice parameters, they summarize it very nicely, and it says testing for food allergy is recommended only for children younger than 5 who have had a persistent eczema, atopic dermatitis history despite optimized therapy, or they have a history of an immediate reaction to the food, i.e. hives. So this sort of is put in perspective when we think about how many overdiagnoses of food allergies there are. And I like to look at this study just to cite it. As I may have mentioned before, there is a great eczema center at National Jewish Hospital. They have an atopic dermatitis program there, and they get kids who have the most severe eczema there for their program, and almost all of them come in with the diagnosis of multiple food allergies. And what they do for these kids while they're addressing their eczema is they go ahead and do food challenges to see whether or not the foods they've been labeled with as a food allergy are in fact real, because a food challenge is sort of the gold standard that we use to determine if the food allergy is real. And what they demonstrated in one particular publication is that they had done 364 food challenges and 89% of them were negative. So these are kids who have severe eczema, and it means that we significantly overdiagnose food allergy in kids that have significant eczema. So here's an algorithm that I sort of use when I'm trying to decide whether or not food is playing a role in eczema and whether or not we are able to keep the child safe. So if they have moderate to severe eczema and I think food may be playing a role and I feel a compelling need to do any tests, then if they have negative tests, I let them have it back into their diet. If they do demonstrate sensitization, let's say to milk or egg, then what I may do is have them take one of those foods out of the diet for a couple of weeks, see if I get any improvement in the eczema. If I do, then I reintroduce the food to see if I get a flare of eczema. Then I take it away again 2 or 3 times till I'm more convinced that yes, they may have some eczema that is significantly affected by that food. And then if that's the case, then what I try to do is put it back in the diet, but in smaller amounts. So let's say I have a mom who tells me that every time she gives the infant 8 ounces of milk, they have a flare in their eczema, then I might say to them, well, let's do baked milk instead, or let's do 4 ounces of milk and use some other supplement for the additional amount of liquid. So what I try to do is bring down whatever the food is to kind of a reasonable level where I still have a little bit of eczema and I have a little bit of food together. Because what we know in kids who have sensitization is if we take the food away completely, sometimes they'll go on to escalate their allergy, and what may have been a food that caused atopic dermatitis is now a food that causes anaphylaxis. And so we've seen it over and over again. The 3 or 4 or 5 months maybe it takes before they have another exposure to that food, it suddenly is a systemic reaction. So if they already have a low level of tolerance, we don't want to take the food away completely. So I'll look for other ways of introducing the food or keeping it in the diet. In the case of egg or milk, it might be a baked egg or a baked milk. And so again, we don't want to randomly eliminate foods from the diet without any clinical suspicion. And when we actually look what food is actually the most commonly challenge confirmed food that's associated with eczema, it's usually egg, but wheat is the most common one that people have false positive skin tests to. So I want to spend just a minute and talk about LEAP, because that's the next question that naturally comes. All of you all are familiar with LEAP. LEAP was the study that was called Learning Early About Peanut Allergy. And basically what it said, in individuals who had severe eczema and egg allergy or both, we wanted to screen them before they had peanut introduced into their diet. If they had mild to moderate eczema, we wanted to, not quite sure what to do, but it probably made most prudent sense to introduce it early. We may or may not screen them. And if the infants had no eczema or food allergy, then you can go ahead and introduce it whenever you want. There was a new publication that just happened in 2021 that says actually in reality, we shouldn't be selecting for kids that have severe eczema. We should try and introduce egg and peanut to all infants, irrespective of their relative risk, somewhere between 4 and 6 months, so that we can actually get this into the diet and keep it there consistently in order to be able to prevent peanut and egg allergy. And this is a bigger change. Whether or not they actually get screened if they have severe eczema isn't mandated. It's really a matter of you can screen them. If you think the family is so anxious about introducing it that they won't, then I would send them for screening so that the food can get introduced. But the most important thing is that we go ahead and introduce it. So then the other thing that you want to make sure is that you provide them with a lot of educational materials, reassure them about the safety. There are lots of good written instructions and action plans that are available. There's this website that's available at the College of Allergy, Asthma, and Immunology that is the atopic dermatitis yardstick that I find particularly helpful when I'm trying to manage patients. There are great handouts at the National Eczema Association, and I oftentimes hand each patient an eczema folder that has some of these handouts in them for them. And so as a result of attending today, what I hope is that you'll aggressively manage atopic dermatitis, don't randomly test or take away foods, and that there are lots of different ways to do things, and hopefully in sort of the hodgepodge of it all, you've got some pearls that you might be able to take away that will help you manage your kids. So I think we have about 7 or 8 minutes left for questions, and so Joe, I'm here and ready, and hopefully I can tackle them.
Very good. So Angela, a few questions here. First question is, and this is kind of real nice follow-up to what you just discussed. So when you have atopic dermatitis in the young infant, is there a role for formula change if otherwise there's no reflux or weight issues?
No.
Good.
Simply.
There you go.
Okay.
Excellent. All right. So is the POEM score free to use in clinic?
Yes, and I use it just like I do the ACT, and I put it and chart it in the patients. We just made up tons of copies, and we just hand it to the family. They score it, and I put it in where my vital signs are.
Awesome. Why warm baths versus cool baths?
So you don't want the water to be too hot, because actually that can, cause erythema in and of itself. It can be, obviously too hot is not safe, but, and it doesn't truly have to be cold. We sort of just say warm because it's more soothing, and it may enable them to spend more time in the tub than if the water's cold. But I don't think an absolute temperature is most important. I think what's comfortable for the child, that they'll be able to sit. I don't think there's any good studies that say it should be 93 degrees. I don't think those exist. So I think whatever's a comfortable bath temperature that your child wants to remain in for a few minutes so you can hydrate the skin is most important.
Excellent. What's the earliest age for food allergy testing, either RAST or skin testing?
So actually, you're born with mast cells, and you're born with IgE mechanisms, and you can be allergic to something very young. You just have to have seen it enough to be able to be sensitized. I have kids as young as 6 weeks who've anaphylaxed to milk. It happens very early in some individuals. So it all depends on what you're testing to. Certainly environmental allergies don't happen till much later. But in terms of food allergy, there's no magic age. But do know that there's sort of, what we may see as an IgE level at 4 months. The machinery gets more efficient and it gets better. So oftentimes somewhere between 18 months and 2 years, I may see a significant escalation in their IgE levels. And it's not because their allergy got a lot worse. It's just because we're testing and they've got more efficient. So there's no magical age for testing, but don't do broad panels. You need to be targeted. I mean, if the child only has, milk in their diet and they've had hives to milk, then that would be an appropriate test to check, but it wouldn't be appropriate to test lentils in a child who's 6 months old just because it's on the panel. You should be very, very careful about what foods you test for in kids who have eczema, because the parents are going to hang on to some number and it may not even be clinically relevant. And so if you get a positive test, you need to come back to someone, preferably someone who has experience doing food challenges, who can determine, is this a real food allergy or is it just sensitization?
Gotcha. This is kind of interesting question here. Is there any difference between atopic dermatitis in infants who are born vaginally versus C-section due to skin microbiome differences? Is there any literature on that?
So there is literature, at least in terms of food allergy. There is some discussion that we see a higher prevalence of food allergy in infants who are born by C-section as opposed to infants who are born vaginally. And the thinking is that coming through the birth canal, you pick up a lot greater diversity of bacteria, and obviously C-section, hopefully there's not that much bacteria hanging around for that. And so there is a difference, and some studies have quoted even as high as 30% difference in development of food allergy, but I don't know of one off the top of my head that at least says so for eczema.
The effect you had mentioned, kind of hard water and the effect on the skin, is water treatment to kind of soften the water beneficial?
It may be. Because of the studies that say hard water is associated with more difficulty in hydrating the skin.
Then can you give a quick example of a cost-effective skin regimen, like for instance, like a non-soap cleanser type of hydration product to use, etc.?
So there are several on the slides. I tend to, you know, whatever the family may have a preference, I use a lot of Cetaphil or CeraVe. Soap-free cleansers are two that I like really well, or Vanicream. And then I usually pick a mild potency steroid cream for the face, and then a stronger potency. And these are by no means, I mean, there's a whole list of everything, but I tend to use Activate for the face, and I tend to use triamcinolone ointment for the body. And in babies, I really like flunacesolone oil or Dermasmooth oil because it's an oil and I can get big body surface areas. But those are just my favorites this week. And certainly I have no evidence to say one is better than another. It's just, you know, you pick which ones you like using, and you can get paid for, and the parents use it, and that's what I go with.
Then kind of a couple of similar questions, Dr. Hogan, is can you go over what a low potency versus a high potency or mid potency steroid is, topical steroid?
And they're basically just what you saw on the, and you get a table, and I have one taped up at my station. If they come in with some steroid cream I haven't looked over, I look over. We really don't want to be using high potency or even moderate potency in class 1, 2, or 3 in general in kids who are with atopic dermatitis because of the chronicity and how long we have to keep applying steroid creams. So in general, I tend to use a very mid potency. And what that means is it has to do with you know, how much steroid is actually there and what the impact is potentially. It goes all the way back to its effects, like when we're thinking about it on the HPA axis, but obviously applied to the skin, it doesn't have as much effect on the HPA axis. But I just don't use high potency. I'm just a little bit more uncomfortable with that.
Then one last question. Can a primary care provider order Eucrisa?
I believe so. I have patients who come to me in my practice that have already been prescribed Eucrisa. There's a little bit of a dance, but it certainly can be done. And also in our EMR, we have the ability to take pictures. We have a folder that's set up that you can take pictures of how their skin looks. And then oftentimes when I send a note off for a prior authorization, I'll drop in a picture of the skin. Look how bad this looks. And sometimes that will help support whatever I might be trying to get a prior authorization for. So if your EMR has picture capability, I take pictures because it's certainly a picture world.
Excellent. Well, we're going to end the session now. Dr. Hogan, thank you. That was a terrific talk, and thank you all the participants for your questions. So
thank you, everybody.
We're going to take a 30-minute
Enjoy the meeting.
We're going to take a 30-minute break. We'll get back at 1:30 Central Standard Time for our next seminar with Dr. Weinstein.